I'll tell you a story about my mother. She was one of four children, four girls, who all got the Spanish flu in 1918. She was one of four sisters. Two of them died.
Oh.
And my mother, thank God, lived. She remembers. She remembers what it was like not to have the vaccine. And I think about her a lot when I'm thinking about no vaccine for COVID, or when people can't get around to it or don't get to it and don't get their flu vaccine.
Aloha, Patricia. Thank you for joining us today.
Aloha.
First, I wanted you just to tell us a little about yourself and your professional background, which I know involved UH, at least for one degree.
Right. Well, I'm a physician, a specialist in geriatric medicine. That's the care of the elderly. And right now, I'm the interim associate dean for clinical affairs at the John A. Burns School of Medicine at UH. And I'm also a medical director of several nursing homes, as well as being the chief medical officer for the faculty practice plan, that is University of Health Partners of Hawaii.
This is a particularly important field for Hawaii because of our own demographics, no?
It is. It's an interesting place to be a geriatrician in that Hawaii is a state with the longest life expectancy of any state, and the longest life expectancy in the world when you take a look at the life expectancy of people of various ethnic groups here in Hawaii compared to what would be their home country. Hawaii's life expectancy is longer.
So far, at least, we have not seen an explosion of cases of COVID-19 in Hawaii. But I want to start off by just asking about where we are in terms of protecting our residents in long-term care facilities, especially the elderly, because this pandemic has just been so catastrophic for residents of these types of facilities.
When you take a look at something like COVID and you take a look at the limited prevention and treatment options that we have, the only thing you can do is to prevent it from coming in. You have to close the door. You have to say, you're not coming here. And when we started seeing the terrible explosion of COVID in nursing homes on the mainland, in particular the state of Washington, where we have friends and we were talking about what was going on in the nursing homes. What we did here was we closed the doors of the nursing home very quickly. We quarantined, just like if you were having a flu epidemic in a nursing home, where we have to quarantine, limit visitors from coming in. We did the same thing. And on top of that, the people who did come in to work or to provide therapy, we were screening them, and we still are screening them when they come in, because that's the way we keep COVID out of the facility.
So in addition to kind of temperature and questionnaire examinations upon entry, do we now have enough testing resources that there's kind of surveillance and testing going on in long-term care facilities?
Well, as you know, testing throughout the state has been very limited. And we've been lucky in that we haven't had to do a lot of testing in the nursing home. Some of the early labs that we did, if somebody had symptoms that we thought could be the flu, we sent off the flu swab with also a reflex to COVID. But luckily enough, we had very few positive flu cases and no COVID positive cases.
And being that this epidemic is likely to last for some time until a vaccine comes online and is widely administered, what do you think we can do better to fortify the protection of these sorts of facilities? Because I imagine that just shutting down visitation entirely will have all sorts of collateral consequences. Are there other interventions in terms of residential density or employment structuring that could help?
Well, what we learned in looking at each facility carefully is, my God, they're a beehive of activity. When we started screening people who came in, that's when we realized how many people do come in and out of the facility every day. The first thing we did was, unfortunately, we had to limit visitors. And the families were not happy about that initially, but when we were able to tell them, it's just like if we had the flu and we had to limit your visiting for a while, we have to do this here, because if COVID comes in, it won't be good for your loved one at all. Then we were taken aback by not only how many staff come in and out every day, but also therapists who come in for one reason or another, or physicians and nurse practitioners who come in to see patients, and the vendors who come in to deliver things that were ordered. The administrator in one of the facilities said she sat by the screening person one of the first days, and she said, my God, this is a beehive. You know, how many people come by? Because she wanted to be sure that the screening person knew exactly what they wanted. But in so doing, it opened her eyes to how many people come in and out every day. And so, but then you realize that that's so often a good thing, and occasionally not such a good thing, where we have people coming in and out to that extent. But this has been a long haul for families. And so one of the things that we've done is we've taken advantage of technology. In many cases, we're able to obtain some iPads and have families talk to their loved ones over the iPad. And it's been quite fun. It's a lot of time taken away from the staff who need to be doing some other things as well. But we said this is priority. The idea that people can't see their loved one is horrible. So we need to be sure that that's getting done. And so we wanted to make sure it was facilitated in every way possible.
Media coverage around COVID is focused mainly on nursing homes, but you know, I know the types of institutions that fall under long-term care facilities are pretty broad. Can you give us a sense of kind of how large this sector is in Hawaii, and what types of institutions there are, and which of them are most at risk in this crisis moment?
You're right. There's some facilities that care for mainly older people and some chronically disabled people that are mainly residential. And you tend to think of the assisted living facilities or facilities that have a range of services under roof. They range from independent living with congregate dining to assisted living with congregate dining and some assistance in the a la carte, usually in the apartment or in the unit. Then and lots of entertainment, things like that to keep a person busy and interested. Those are mainly residential. Then there are over 400 or so care homes in the community. What those are, if you drove by it, it would look like someone's house. And it is someone's house. Mm-hmm. And it's they're licensed, or they should be licensed, to care for usually 2 or 3 people who need assistance, cannot live on their own. Then when you're talking about nursing homes, you're talking about what in the federal language is called nursing facility, or NF. And within that facility, there would be 2 levels of care. There's a skilled nursing facility, or SNF level, and the LTC, or long-term care level, that's also called intermediate care level. SNF patients or residents in those facilities usually have spent some time in the hospital. They've had an injury or an illness which has rendered them so debilitated that they can't go straight home. They need skilled nursing for for treatments and for medication administration. They're really a medical patient. They're usually there in the SNF level for a short period of time, usually several weeks before they can go home. A ICF or long-term care patient is someone who doesn't have a home to go back to, is multiply impaired. Let's say they had not one, but a couple of strokes. They can't get out of bed by themselves. They certainly can't toilet themselves. And their mobility is mainly in a wheelchair. And so sometimes those people end up staying in the nursing home at the long-term care level of care.
I have a question also on the clinical side of the COVID disease. I think maybe we too often take for granted that this virus would claim a greater number of elderly victims, but what do we know about what the reasons for that might be? Is there some extra or distinct susceptibility? Is it comorbidities? Is there a distinct immune response, or something I'm not enumerating?
Well, now we've seen that that the coronavirus, COVID-19, that causes the COVID-19 disease, has a predilection for older people and people who we talk about some underlying illness like hypertension, diabetes, cancer, some other condition that makes them vulnerable. And now they get COVID virus and their immune status is not strong enough to fight off something else, especially if they have respiratory problems to start with, such as COPD or chronic asthma, chronic respiratory conditions. Viruses are really different. They're sneaky critters. And some, as we've seen, may have a predilection for children for some reason. Others have a predilection for people at all ages. And some, as we've seen, maybe it occurs in people of all ages, but mainly the people who are already old and vulnerable just have a much poorer outcome.
And I guess the research is still unfolding as to how all of those work together in this particular case. On the treatment side, are there studies underway or emerging research that suggest the possibility of different treatment protocols for elderly?
Well, you can imagine that scientists are working all over the world to find what's going to work with this virus. And people are trying all kinds of things. And so thank goodness for the scientists who spend their lives actually fighting off disease, because physicians get a lot of credit, but we wouldn't have anything to offer except, our good company if we didn't have scientists who are discovering medications and how they work and how they can be produced more rapidly and when they should be used. There's all kinds of things we need to know. And with COVID, we've got people all over the world that are working hard to try to find treatment. And sometimes because they're desperate, certain treatments get tried that you're not sure if they're working, or you have only anecdotal results because you're thinking that it might have worked, but maybe the person was getting better on their own already. There's all of that now going on in the early months or in the first year of this virus.
In the meantime, and until some of these treatments kind of show real promise, or until we have access to a vaccine that's safe and can be administered at scale, we're left with trying to protect people from getting infected in the first place. There's a lot of federal money sloshing around in the economy right now. If some of that could be deployed to geriatric medicine and long-term care facilities, where should it go?
Well, right now, if we find medications that actually reduce people suffering from the disease, of course that's where it should go. If all things being equal, if you can hire more people to care for people who are weak and sick, that's really wonderful. But it's expensive to hire staff for facilities, and as it is, nursing home cost is pretty high. It ranges from say 11,000 to 15,000 a month on average. And you think, oh my God, where's that money going to? And then you think, well, you've got aides round the clock, you've got skilled nurses who are doing medication administration and providing nursing care, doing IV therapies and whatnot. You have, and providing some respiratory assistance to a lot of the patients who need those treatments. And so then you have layers of administration that's also required, because there are very strict regulations for how nursing homes are administered, what they need to have. That's an expensive operation.
Well, and maybe in an ideal world, they should even be more expensive, I'm thinking, in light of this pandemic. Like, you know, there's a lot of these aid jobs are not structured very beneficially for the worker in terms of sick leave, for example, which obviously can be dangerous. And, you know, I wonder also about congregate sleeping arrangements, you know, if those pose some long-term risks during a regular flu season, and especially in a moment like this, whether we should have, and even whether really as a wealthy country, we ought to have a more resource-intensive way of taking care of our most vulnerable citizens.
Well, if I could build a nursing home, and you asked me how it would be structured, we clearly have the administrators, the nurses, and aides. But I'd also like to build many more private rooms. In the nursing homes, you'll see that it's very few private rooms, if any. Usually there are 2 bedrooms, but sometimes also 3 and 4 bedrooms, trying to build a facility that can be run with the reimbursement levels that are possible. But if I could design one, it would have a lot of private rooms. That helps, for one thing, it helps to reduce the spread of infection from one person to another. And so that if we had to do a quarantine because of flu or COVID, we could do it much more easily with people in private rooms than in shared rooms who have already acquired the virus from their neighbor.
You know, there's also very modest funding in Hawaii to try to assist families caring for loved ones at home. The Kupuna Care program, for example. You know, I'm just wondering your opinion about, as we move out of this pandemic and think toward caring for our elderly population for the long term, is that also an area that might need renewed attention?
That's right. We just can't rely on government sources for everything. It's the sort of thing people need to be very much more aware of early in their life. When, for example, if you were to buy long-term care insurance and you're in your 20s or 30, what you'd have to pay every month for a good amount of insurance would be much less than if you're already in your 60s or 70s, if they'll sell it to you. As an insurance person once told me, you can't buy fire insurance if your house is on fire. And so if you need long-term care, you're already at an age where something might happen to you that unfortunately you might have to use it, you're going to have to pay a lot more, and the benefit's going to be a lot less.
I wonder also, thinking in very general terms, if you feel like this attention on the elderly population might also help us as a society appreciate the diversity and the features of the population a little better. Like, do you feel like there are a lot of misperceptions about the elderly population in terms of mental health or even personality profile? psychological development, and so on?
You stop and think about it, the older population is very diverse. And by that, I mean not so much in ethnicity, but in their physical well-being. If you took, let's say, 100 25-year-olds, and in that 100 people, you would measure their renal function, their mental ability, their physical ability, except for some well-trained athletes and a few geniuses, people tend to be very much like each other. Now, let's say you're going to take 100 80-year-olds, and you go with that 100, you're going to check their kidney function, you're going to check their cardiac output, you're going to check their mental functioning, their ability to remember things, and on and on. You're going to check the same things that you checked in your 25-year-olds. Then you'll find that people are very, very different from each other. You have an 80-year-old who unfortunately has had a stroke or two that needs help getting out of a chair. You have an 80-year-old who unfortunately can stand on a chair to change a light bulb in the ceiling. And you don't want them to do that, but they can. And you have people who are very functional, running businesses in their 80s and 90s. I know someone who's 90 who just took on a new job because his skills were such that they were needed. But you have people who are much younger than that who unfortunately become impaired through Alzheimer's disease or some other kind of dementia, and they need a lot of help with their functioning. They have very bad memories and very bad judgment and need a lot of help taking care of themselves.
You know, where would you hope Hawaii ends up from this in terms of elder care and research and medicine, say 5 or 10 years from now?
Well, I've been thinking that we're all going to take less for granted. We've been pretty much at an equilibrium for a while. Although there have been advances in medicine, I can't think of any huge breakthroughs. We've been making small breakthroughs, not small for the people who've been healed, but not so you'd find it splashed on the front page of the newspaper. Those kinds of, and we've had great medications, and yet the improvements in the medications have usually been that they have fewer side effects, maybe a little more effective, maybe not. So we haven't seen anything huge. This is huge. I think what we'll have is a greater focus and appreciation for those things that we have vaccines for. For example, we've had flu vaccine a long time, and those sneaky viruses, they have different strains that you've heard about, and there's been some improvements there as well in the with how many strains the virus will cover. We now have vaccines that cover 4 strains instead of 3. We were lucky to be able to do that, or the companies were able to do that. We now have learned that high dose flu vaccine in older people is more effective than the regular dose. So those kinds of advantages have come along. Now, even with that, we've had to beg some people to take their flu vaccine. You know, we push and we cajole and we recommend and we work hard to get people to get their flu vaccine. Next year, I wonder if we'll have so much trouble getting people to take their flu vaccine. You know, we've had so much focus on the praying for and working towards a vaccine against COVID, or at least one of the strains of COVID. And we're praying for that. We're hoping that comes along. We've already got flu vaccine. And I'll tell you, if you have a case of flu and then you get COVID, you're going to have a really hard time coming out of that, if ever. So next year, I'm hoping we don't have such a hard time convincing people they should at least take their flu vaccine. I'll tell you a story about my mother. she was one of 4 children, 4 girls, who all got the Spanish flu in 1918. She was one of 4 sisters who got put in the big parents' bed. They were very sick, and the mom was taking care of all 4 of them. 2 of them died.
Oh.
And my mother, thank God, lived. She talked about it every now and then when sometimes when it came to getting her flu vaccine. I think she was the first one in line at the doctor's office when the flu vaccines came out. She remembers. She remembers what it was like not to have the vaccine. And I think about her a lot when I'm thinking about no vaccine for COVID, or when people can't get around to it or don't get to it and don't get their flu vaccine.